Good morning.
Good morning.
We are starting our academic program for the month of May. The first program today is a case presentation by Dr. Rajkumar, who is a third year DNB PGT at MR Bangalore Hospital. And to me today is Professor Prashanta Kumar Bhattacharjee, who is professor and head of surgery at Bakura Shumili Medical College. So we will have the presentation and discussion as we go usually. Dr. Rajkumar, please.
Good morning, faculties and my dear colleagues.
Yeah, start.
42 years old female, Sandhya Haldar, Hindu, housewife by occupation, coming from Santoshpur, attended the surgery OPD with the chief complaint of swelling in the front and the side of the neck for the last 3 years. History of illness. Patient was apparently well before 3 years. Then she noticed the swelling in the left side of the neck 3 years back, which was about 2 centimeters in size initially. The swelling is increasing in size very slowly over the last 3 years, and the swelling extended to the midline and to the other side, right side of the neck. There has been no history of rapid increase in the size of the swelling, and no history of any pain associated, and no history of any pressure symptom, no history of difficulty in swallowing, no history of difficulty in breathing or hoarseness of voice, no history in change in appetite or weight gain, no history of intolerance to hot or cold, no history of palpitation or shortness of breath, no history of insomnia and nervousness, no history of any other symptoms suggestive of hyper and hypothyroidism, no history of any disturbances in the bladder and the bowel habit, no history of any other swelling in the neck or body. Past history, no history of radiation exposure in the head and neck, chest area, no history of any similar illness in the past. Personal history, she is taking Mixadire, no addiction, married, her husband and 2 children, they both are healthy and sleep pattern is normal, and she passes stool once a day, semi-solid, inconsistency, bladder habit is normal. Menstrual history, she attained menarche at 13, 28 days cycle, regular 3 days period, normal flow, and last menstrual period is 24-20-21. And obstructive history is para 2, live 2, A0. Family history, no history of any thyroid disease or similar illness in the family members or neighbor. Treatment history, no history of any prolonged drug intake, no history of any treatment for the same disease. Allergy history, no history of any known allergy. Summary of the history, a 42 years female coming from non-endemic area came with a swelling in the left side of the neck 3 years back, which was about 2 centimeters in size initially. Then it started increasing in size very slowly over the last 3 years, and the swelling extended to the midline and to the right of no history of rapid increase in size of the swelling, no pressure symptoms, and the appetite is normal, bowel and bladder habits are normal, and there are no other symptoms of hyper or hypothyroid pertaining to respiratory, cardiac, and nervous system. There is no history of any major ailment in the past. There are no menstrual problem. No other in the family members has similar swelling in the neck.
Okay, Dr. Bhattacharjee, we can have some discussion on the
as far as the site of the swelling is concerned, you said it is on the left hand side, isn't it? Left hand side, and then it approached the midline. Hello.
Yes, sir.
Yeah. So I think it will be better if you say, and you of course mentioned that it's in the front of the neck. So why don't you add a little bit more that it is in the front and the lower part of the neck? That makes things a bit more localized as far as the site of the swelling is concerned. Front, sides, and the lower part of the neck, instead of, because neck has got an upper part, lower part, isn't it?
Yes.
So lower part of the neck. What are the causes of pain? As you said that it's not associated with pain.
Yes.
Causes of pain in a swelling, in a thyroid swelling?
Associated with any hemorrhage and any malignancy, it causes pain. Apart from associated thyroiditis.
Very good, thyroiditis. Regarding the progress, you said there is no history in the history of sudden increase of the swelling, isn't it? That's what you said? Rapid increase of the swelling. That's what you said, no?
Yes,
rapid
sir.
Increase, yeah. So what are the causes of sudden increase in the size of a swelling, in a thyroid swelling?
Again, hemorrhage and malignant change.
Malignant will not cause a sudden increase. Hemorrhage will cause a sudden increase, isn't it?
Yes.
So I think that words are somewhat, like in a hemorrhage, it will cause sudden increase, and malignancy, it will be a rapid increase rather, isn't it? A little bit of a subtle difference between sudden and rapid, isn't it?
Yes.
Yeah. Did you comment about any other swellings in the neck?
Yes, sir. No history of any other swelling in the neck or body.
It doesn't. Okay. What did you mention about the? I don't think you have mentioned about the residence where from the patient hails. She hails from which part?
So Santoshpur, which is a non-endemic area.
Okay. All right. What is the importance of noting the residence?
It is the goiter. I mean, the thyroid swelling. The goiter is present over the goiter belt of India, which lies along the Gangetic belt, the Himalaya, Himachal Pradesh. They lies over
endemic areas, as you said.
Yeah.
When do you say that the goiter is endemic, by definition? Hello, did you get my question?
Yes, sir. Yes, I get.
Yeah, there is a definition. Like, if I think you are not sure about the definition.
Yes, sir.
Hello.
Yes, sir. I don't know that.
Yeah. So it is said to be endemic if the prevalence of goiter in the children in the age group of 6 to 12 years is more than 5%. If it is less than 5% in that area, in that age group, then it is said to be sporadic. All right.
Okay, sir.
All right. By definition, that's what the definition is. Regarding dietary history, you said she takes mixed type of diet, isn't it?
Yes, sir.
So what dietary history is important as far as thyroid swelling is concerned?
History of taking any goitrogenic diet, like belonging to Brassica family.
Yeah. And does it have a history with the? Does it have a correlation with the family history also?
Is because the same family, same
Yeah,
they take the same
that's
diet.
right. So if the same family, other family members take the same diet, it may be running in the other members of the family. And what is the other cause of the goiter running in the family?
Hold on.
Other family members?
Any C cancer, enzyme deficiency, the
Yeah,
dysharmonogenesis.
dysharmonogenesis. Very good, very good. Anything about the? You said something about the treatment. Like you said, she is not on any regular medication or prolonged medication, isn't it?
Yes, sir.
What type of drugs are you concerned about? Which type of drugs can, prolonged use of which type of drugs can lead to development of goiter?
Whether she's taking any other thyroid medication or amiodarone like that drug, or is she under treatment for any hyper or hypothyroidism, like antithyroid drugs?
No, no. Any other? What I mean to say is, what are the drugs which can lead to the development of goiter? Goiterogenic drugs, rather. Like one you said is amiodarone. Any other drugs that you know of?
Like,
All right. Para-aminosalicylic acid, have you heard?
Anti-TB drug.
Yeah. Okay. And in dietary habit, you should also mention just a sentence that what type of salt he takes or she takes, that she takes iodinized, iodine supplemented salts, isn't it?
yes.
I think the rest of the, you said, told a few things about the pressure symptoms. What pressure symptoms are you concerned about as far as a goiter is concerned?
Whether it is pressing over the trachea causing difficulty in breathing, or esophagus difficulty in swallowing.
This difficulty in breathing, it's occurred throughout the day or in particular time of the
nocturnal, during sleeping.
Why? Usually it is seen like when the patient lies down, okay, and the patient's neck is somewhat flexed laterally and forward. That is the position in which this the thyroid will be pressing, the enlarged lobe will be pressing upon the trachea. Okay, so it's not so much apparent during the daytime when the patient is walking around, but when the patient lies down with the neck flexed somewhat laterally and forward, that is the time when the dyspnea sort of gets aggravated. All right. Dysphagia, is it very common with thyroid swelling?
No, sir.
Why not? Like dyspnea is quite common. Why not dysphagia? But we routinely ask about dysphagia, but is it very, it's not very common. Why not?
It is the swelling is little anterior to the esophagus. It's over the thyroid, it's over the trachea.
Yeah, esophagus is quite posteriorly, isn't it? It's right at the posterior aspect. Trachea is in front, number one. Number two is, it's a muscular structure, isn't it? When the trachea is a stiffer structure, so it'll not be too much sort of elastic, while the esophagus is a muscular tube, so it can be pushed. The thyroid swelling can push it aside, but still the patient can continue taking food along. Okay, continue with the process of deglutition. So it's in the very late stage that the dysphagia becomes apparent in the thyroid swelling. All right, but more than the dysphagia, it's more of a discomfort that the patient complains of because of the big swelling in front of the neck, isn't it?
Yes.
What are the causes of hoarseness of voice?
It is due to involvement of the recurrent laryngeal nerve.
Involvement by
infiltration,
malignant thyroid swellings, or by pressure also, isn't it? It may be by pressure, simple pressure, or by infiltration by malignancy. Okay, then you talked about hypo and hyper features of hypo and hyper thyroidism. Bony swelling. You talked about other bony swellings. Which type of goiters are associated with bony swellings?
So if it's malignancy, it might be a
which type of malignancy?
Follicular CA.
Yes. Okay. All right. Professor Shah, I think he has done I mean, all the answers were excellent.
I have few questions with him. One is, you are right in saying that there is an endemic zone of goiter, but nowadays you will find we don't find such huge number of goiter patients coming from the hill areas.
Because they also take iodized salt.
This is a rule. It's a Indian government has made a rule that all salt sold in the market should be iodized. That's why people in hill area is also the iodized salt. So it's not that he's getting less iodine. So this is a defined endemic zone, agreed. But nowadays, with legislation of getting iodized salt in all places, the incidence has gone down to a substantial extent.
Exactly.
Secondly, when it comes to history of present illness, you see, I would prefer to have a chronology of description. You said you have started describing the swelling, and the same slide, last point is no other swelling in the neck or body. You finish up the swelling history in one paragraph. Any other swelling in the neck. Next is, if you talk of thyroid case, you are concerned about two things. One is to find out any symptom of hypo or hyperthyroidism. And second is, if you suspect a malignancy, you want to exclude whether the patient has metastatic symptoms. So you see, you have studied appetite, weight gain. Then you have gone to internalize the hot and cold temperature. Then you go to breath exertion. Then go to neural symptom. Again, you're coming to the abdominal symptom. What I prefer to do is, I'll start with GI symptoms, appetite, weight loss, any abdominal distension, any lump in the abdomen, any swelling in the abdomen, any history of jaundice. So these four symptoms cover my, and the bowel habit. How many times is by any history of diarrhea. So these 4-5 symptoms cover my symptoms of hypothyroidism and metastatic symptom. Next, I come to the chest. Any chest pain, cough, hemoptysis, any exertional breathlessness, exertional palpitation. That completes my chest symptom. Then I go to neural symptoms. Any restlessness, any history of insomnia, any irritability, any trembling of the limbs, any symptoms of tendon palsy, any symptoms which will suggest any weakness of any of the limbs. So if you go by chronology, in the exam you will not miss it. So make a habit of starting the system with the GI symptom, then chest symptom, then neural symptoms, and then describe musculoskeletal, any swelling in the bones, any recent onset of low backache. So if you go through this, It is a good chronology of going through each of the system, and you don't miss out anything. It covers everything. When you go to summary, you need not say so many things. In summary, 3 lines is good enough. Patient has no symptoms of hyper or hypothyroidism. Patient has no symptom suggestive of distant metastasis. So you need not describe everything. But history is the area where if you are allowed to narrate, you have to space for this description. Otherwise, he has mentioned every point and he has answered very well in the examiner's question. That's good. Okay, we can pass on to examination, Dr. Bhattacharya.
Yes.
General survey. I examined the patient after taking consent in a well-light room in the presence of a female chaperone. Patient is conscious.
Well lit room. Lighting.
Well-lit room.
Well lit.
Patient is conscious, alert, cooperative. Current performance scale is 90%. Average build and BMI is 20.5. Faces is normal. Gait is normal. Hydration state is well hydrated, well nourished. No pallor, jaundice, cyanosis, clubbing or edema, ingots, neck veins. No cervical lymphadenopathy. Skin and palms normal. Pulse rate is 80 per minute. Regular in rate, normal in rhythm, normal volume. No radiofemoral, no radio delay. No special character. Condition of the vessel wall normal. BP is 120/80 measured in the right brachial artery in the sitting position. Respiratory rate is 16 and temperature is normal. Examination of the thyroid region. Inspection.
Just a moment. In general survey, again, few questions. Like, for example, you, the look of the faces of the patient, that is important. The face appears normal, you said, isn't it?
Yes, sir.
What type of changes that you can expect in the general appearance of the patient, the patient's face?
I mean, swelling, mixed edema, the face, mixed edemic faces.
Puffiness, facial puffiness.
Facial puffiness can be seen.
Okay, next. For hypothyroid patients. On the opposite side, patient can have a very anxious type of a look, irritable, anxious type of look. The patient will be sweating. The face will be sort of sweating. There may be flushing of the face, isn't it? In case of toxic patients. All right.
Yes.
Then skin, what changes do you expect in either side?
In skin and palms, in the case of hyperthyroidism, it will be moist, sweaty. In hypothyroidism, it will be dry.
Warm and moist in hyper, and in case of hypo, it will be dry, coarse type of a skin, isn't it?
Yes.
Any other skin changes that you can expect?
Yes, sir.
On general survey?
In mixed edema can be seen in limbs, lower limb.
Pretibial mixed edema.
Pretibial mixed edema can be seen in the lower limbs.
Okay. Pulse, what changes can you expect?
Pulse, if it's causing some any collapsing pulse, like cardiac failure.
You say that in hypothyroid, if patient is hypothyroid, I'll get bradycardia. The pulse may be a little bit irregular. While in case of hyperthyroidism, I'll get tachycardia. And what you said, collapsing pulse, water hammer type pulse, isn't it?
Yes.
Yeah. And all types of arrhythmias.
And there may be arrhythmias, yes.
All types of arrhythmias can occur.
What are the types of arrhythmias, yes, that you can get in hypothyroidism?
Extrasystole and paroxysomal atrial fibrillation and paroxysomal supraventricular tachycardia. Atrial fibrillation.
And even features of heart failure also in the later stage. Like, one liner is all types of arrhythmias can occur in hyperthyroidism, including ventricular extrasystoles. Okay, all types of arrhythmia can occur, including the last point is patient may have cardiac failure. So edema is very important. Then you said about clubbing. What is the importance of clubbing? Noting whether the patient has clubbing or not.
Yes, associated thyroid acropathy can present with clubbing.
Very good. Very good. All right. And in respiration is also important. You should mention that the patient is having normal rate or respiratory rate or not. Or for example, in hyperthyroidism, that way, patient may be a bit tachypneic, isn't it? All right.
Next.
Person two. Local. Yes.
Examination of thyroid region, inspection, position and extent of the swelling. Both the lobes of the thyroid gland are enlarged and extend above up to the thyroid cartilage, and below up to the clavicle, and laterally up to the posterior border of sternocleidomastoid. The isthmus of the thyroid gland are also enlarged and extend below up to the suprasternal notch and extend 3 cm approximately above the suprasternal notch. It's a butterfly-shaped swelling, and size on inspection all are approximate. Left lobe 4x3, right lobe 3x2, and isthmus 2x2. And the surface appears to be nodular, margins seems to be rounded, and skin over the swelling normal, no visible pulsation, and the swelling moves with deglutition, and the lower border of the swelling can be seen, and no venous prominence over the neck or the chest wall.
You finish on the examination.
Palpation, temperature is normal, not tender, and swelling moves with deglutition. And inspectory findings of position, extent, shape, size, and dimension are confirmed by palpation. And the circumference of the neck at the most prominent part of the swelling is 22 centimeter. Surface nodular, margin is rounded, consistency firm, and no pulse felt, no thrill, no skin fixity, and mobile from side to side and up and down. And the swelling passes under the sternocleidomastoid muscles on lateral side, and position of the trachea normal, and focus stress is negative. Carotid pulsation is normal in position. Percussion not done, auscultation no bruit. Examination of cervical lymph nodes not palpable, and examination for toxic signs and signs they are absent. Systemic examination, CVS S1, S2 her, no murmur. Respiratory system normal, vesicular breath sound, no adult sound. Per abdomen soft. CNS in no focal neurological deficit. Summary of the case. 42 years.
Can we, before summary, can we ask a few questions on
Yes, Dr. Vatsal.
Yes. You have mentioned about, you said that the swelling is, the consistency of swelling is firm, isn't it? That's what you said.
Yes.
Huh?
Yes.
I think it would have been better if you had said that, yeah, because it's a nodular goiter, as you said. So there are a number of nodules, isn't it? Huh?
Yes, sir.
Hello.
Yes, sir.
You should comment a little bit more about the distribution of nodule. Like that, there are multiple nodules involving both the right and left lobe of the thyroid and the isthmus, or one particular nodule is larger than the rest. Okay, that like a dominant nodule. Then the consistency, instead of saying firm, because the nodules can have variable consistency. Some nodules may be a bit cystic, some nodules may be hard, isn't it? Whether it is like that or not. I mean, in your case, is it a uniformly firm as far as all the nodules are concerned, or is it has a variegated consistency? Is it important?
Yes, sir.
Is it important to note whether the nodules are having different sizes, one particular nodule is larger than the other, and whether they are having a variable consistency or not?
Yes, sir. To rule out whether it is a dominant or nodular.
Yeah, and it's like, for example, if a particular node appears to be quite firm, and then it goes more that it can be harboring an underlying malignancy. But there is a fallacy also, like for example, at 10 cystic swelling may appear firm, isn't it?
Yes.
While cystic swelling can also harbor underlying malignancy if it is a complex type of a cyst, isn't it? That is so you should mention a little bit about the consistency of the nodules instead of just saying it is a firm. The thyroid is firm in consistency. And then you said percussion was not done.
Yes, not done.
Is there any role of percussion as far as thyroid swelling is concerned?
If I am able to locate, to see the lower border of the swelling, there is no need to.
Not okay. Take it. So percussion is not done. So just mention line that since the lower margin of the swelling is both visible and palpable, I didn't do any percussion on the manubrium sternum. Auscultation you didn't mention?
No bruise.
Did you?
Written.
Huh? You
Yes, sir, no bruise.
Oh, no bruise. Where do you look for auscultation?
In the superior pole of the swelling, superior pole of the thyroid.
Superior pole of the thyroid. All right. And what few signs? Pemberton. What is Pemberton sign?
Pemberton sign in the case of, should I explain this?
Just mention.
It is done in the case of retrosternal prolongation. And the patient is asked to raise both the arms close to the ears, above the head. And you should maintain the posture for around 5 minutes. In the case of retrosternal prolongation, the patient start having swelling of and flushing of face, veins get engorged, and patient complains of respiratory distress. So it is said to be positive. There is, if this happens, and it's a sign of retrosternal prolongation of the goiter.
Very good. And what is Berry's sign?
Berry's sign, the carotid pulse is not palpable due to the infiltration of the carotid sheath by malignancy.
What are the?
It is said to be positive if it is not palpable.
Okay, so if you are asked what are the findings in case of a retrosternal prolongation, 1, 2, 3, 4.
From the history, patient patient complains of any respiratory distress or swelling of face and flush, engorged veins, and an examination same will be noted, and I cannot see the lower border of the swelling, and the Pemberton sign is positive.
Next.
Patient may complain of stridor.
Percussion over the sternum will be?
Percussion over the, it will be dull.
And finally, finally radiological confirmation, isn't it?
Yes.
Can you have an idea as to whether the trachea is deviated without palpating, like without touching the patient? Can you have an idea as to whether the trachea is deviated to one side? By just inspecting?
In the case of huge thyroid swelling, it's tough to make out.
No, it is said that there is a sign. It's called Tracheal sign. Yes, Tracheal sign, where you find that sternocleidomastoid muscle on the side where the trachea is deviated is more prominent than the other side, isn't it?
Yes.
All right. So, any other questions, sir?
Come to the first slide. Inspection. You see, it started with the heading of examination of thyroid region. This is a case of thyroid swelling, you said, but keep in mind that this is the examination of the neck, because level 5 node is not in the thyroid region. Thyroid region is a defined area where the thyroid gland lies. So heading here should be examination of the neck. Just keep like that. And I prefer a postgraduate student to start their description like this. Instead of starting the description of the swelling, you can go for the thyroid. Thyroid gland is enlarged, involving the both lobes in the isthmus. And now my next question. Why do you say this is a thyroid gland we are looking at? What are the points in favor of your statement that this is an enlarged thyroid gland?
It lies in the thyroid region.
First is start again in the history. Patient complained about swelling in the thyroid region, and you know what thyroid region is. And on examination, I found what?
The swelling moves with deglutition.
Yes.
And
first is location. Swelling is within the thyroid region, and the swelling moves up and down in deglutition. So that is the reason. So once you have
why does the swelling move up and up with the deglutition?
The thyroid gland is invested by the pretracheal fascia, and which is continuous with the trachea and the cricoid cartilage. And the second thing is there is a condensation of the pretracheal fascia and the Berry's ligament, which touches the medial surface of the thyroid gland to the trachea. So sorry, the cricoid cartilage. As during deglutition, the cricoid cartilage and the trachea moves along up and down during deglutition. As this thyroid gland is also attached to that, it moves along.
So keep in mind this point. In the exam, don't say only the Berry's ligament. Berry's ligament is one of the part of the petechial fascia, and this petechial fascia is one of the prolongation of the cervical fascia, which splits to include the thyroid gland, and on enclosing, it gets fused with the trachea and the larynx. So one is attachment of the gland with the larynx and trachea by the petechial fascial extension, and part of the petechial fascia gets condensed and thickened, which is attached to the cricoid cartilage. So it is not only the Berries ligament which moves the thyroid gland. It is the whole of the petechial fossa, condensation, and the Berries ligament. Fine.
And why does the larynx moves with deglutition? Hello?
Other people should be muted. Other people should be muted.
What is the mechanism by which the larynx gets lifted
Why
up?
does the larynx move with deglutition?
It's sort of hyoid bone and
Why it is necessary, in fact, to get the larynx shut off during deglutition? Because you see, the oropharynx and the nasopharynx area, as you go there, they crosses. So while you swallow, you want the laryngeal inlet to get closed. While you swallow, you need the laryngeal inlet to get closed. So that is the protective mechanism.
And the oblique fibers of the pharynx. Pharynx have got some fibers. There are some horizontal fibers and some oblique fibers. The oblique fibers gets attached to the thyroid cartilage, lateral aspect of the thyroid cartilage, and that when it contracts, when the pharyngeal muscles contracts, it will pull the larynx up automatically. And as the larynx moves up, it also pulls the thyroid gland along with it. Okay. That is the explanation.
Which thyroid swelling does not move with deglutition?
Yes.
If it's a huge thyroid swelling, then in case of carcinoma of thyroid infiltrating the trachea,
Keep in mind, only tracheal infiltration will not prevent moving with
the
deglutition.
local infiltration.
Yes, where?
Local muscles.
Where?
In the strap muscle.
Strap muscle will move. If it is in the prevertebral muscle and the cervical vertebral body. You see, just because it is attached to the trachea and larynx, it moves with deglutition. So if a malignancy infiltrates the trachea, will still move with deglutition. If this infiltration occurs into the prevertebral muscle and the cervical vertebral body, it will not move. Okay? And some thyroiditis where in addition to larynx fixation, it can cause to the local fixation because of the thyroiditis. The other swelling which doesn't move with deglutition. Good. You can go on to the
any other swelling which moves with deglutition other than thyroid?
Subhyoid bursitis and pretracheal prelaryngeal lymph node, and early swelling arises from the larynx or the trachea.
All right.
I think you should make a heading of examination of cervical lymph nodes. You made a heading of this in the local examination. Lymph nodes, yes. And don't make so brief. CNS, NFND. At least write few points. System examination of the abdomen. Shape of the abdomen normal. Umbilicus central. No organomegaly. No free fluid. At least write one or two lines. CNS, NFND. I cannot make out initially what is NFND stands for. So write few lines at least. Only describe is a system examination, one line. System examination is essentially normal. That's it. Your job is over. But if you're allowed to write and present in details, try to present a few lines. Come to summary.
Tendon reflexes he didn't mention, no?
He has gone for toxic signs, so that is again a brief. So for again toxic signs, you should write eye signs absent, no exophthalmos, then write tremors, then write petechial myxedema, reflexes. So you make a heading, at least you can understand that these are things you look for under the heading of toxic signs.
Exactly. Any musculoskeletal signs that can be seen in toxic thyroid?
Is proximal muscle weakness is seen, and myasthenia-like syndrome.
Very good, very good. Okay. Okay.
Summary of the case: 42 years female from non-endemic area came with swelling in the left side of the neck, which was about 2 centimeters in size. The swelling is increasing in size, and the swelling extended to midline and the right of the neck. No history of rapid increase, and no history of any pressure symptom. And bladder and bowel habit are normal, and no symptom pertaining to hyper and hypothyroidism. There are no other in the family members a similar swelling in the neck. On physical examination, general survey is essentially normal. On local examination of the neck, there is a swelling in the front and side of the neck in the thyroid region, and the swelling is butterfly shaped, moves up and down with the deglutition, suggesting it could be a thyroid swelling. The left half of the swelling measure 4 × 3, right half 3 × 2. and midline 2x2. On either side, the swelling extends above up to the upper border of the thyroid cartilage and below to the up to the clavicle. In the midline, the swelling extends below up to the suprasternal notch and above 3 cm from the suprasternal notch. The surface of the swelling is variegated. The margins are rounded, and on the lateral side, the swelling passes under the sternocleidomastoid. The swelling is firm and variegate in consistency and non-tender. The carotid pulse is palpable in the normal position on both sides, and cervical lymph nodes are not palpable. And circumference of the neck at the most prominent part of the swelling is 22 cm. No toxic signs are found. No clinical evidence of retrosternal prolongation.
Next, diagnosis.
It is a diagnosis is a case of non-toxic multinodular goiter involving both the lobes and the isthmus of the thyroid gland, probably benign.
Okay, you see, our national teacher, Dr. Chintamani, prefers not to say 42 years female or whatever. So make a habit of saying that 42 years lady or a 50-year gentleman, whatever. So don't use this term. He does not prefer, and then most of the examiner now prefers to have this. Okay, so you can start with the discussion.
So what investigation would you suggest to this patient?
Let him justify the diagnosis.
Okay, justify. Okay, so what do you say it is? Both lobes and isthmus. Take it, ball.
Again, you have summarized, no?
Yes, sir.
In examination, you started saying that the thyroid swelling will involve both lobes, and in summary, you started describing so much. It's not required. When you come to summary, you say there is diffuse enlargement thyroid gland involving the both lobe and isthmus, and even dimension is not required in summary. The extent is up to this. Surface is nodular, variegated in field, no fixity with the underlying structures, no fixity with the skin. No evidence of any rationale prolongation, no toxic signs, no cervical lymphadenopathy. So when you summarize, you give the brief points. You not give the, again, size, shape, everything you have described in histopathology. It's meant not to come in the summary part. It becomes a little wider, you see. Your whole summary become more voluminous. Itna nahi hai. Zarurat nahi hai. Okay, you justify the diagnosis. Why do you say it's a thyroid swelling? You have said that.
It's a swelling.
Why do you say it's a non-toxic goiter?
Because no signs of toxicity is present.
No symptoms and signs. Both.
No symptoms and signs of toxicity is present.
Why do you say it is a benign swelling?
No symptoms suggesting of malignancy is present. And it's a slow.
Slowly. I say that this patient has a swelling in the thyroid region for 3 years, which was increasing slowly in size. There is no history of rapid increase in size of swelling.
No
patient has no pressure symptoms. Okay. Patient has no metastatic symptoms. On examination, I found a swelling which is having variegated field. There is no evidence of pressure symptom. And in the examination, you mentioned about Cocker's test. You need not say in the exam, you have done a Cocker's test. If the patient has got a stridor and this swelling is for 3 years and patient having stridor, you need not, if the history of stridor is there, don't do it. This can aggravate the patient's symptom. So Cocker's test in the examination part, don't mention. You'll examine and ask whether done it. You should say that this patient does not have any stridor, 3 years history of this swelling, easily mobile up and down. So it is not necessary to demonstrate this test. All tests need not be done in all patients. So skip Cocker's test being mentioned in the history presented in the examination. Okay. So, and benign because the swelling is variegated in field, the swelling is moving in declination, and then there is no fixity, there is no recalcitrant palsy. Okay. So the
no lymph nodes, no palpable lymph nodes.
No palpable cervical lymph nodes. Yes. Okay. So you can pass on to the management part. Yes.
What investigation would you suggest, stepwise?
I like to do investigation to confirm my diagnosis, and other investigation for planning my treatments.
Here I have an observation. The more examiner now prefer to say that in breast you say triple assessment. Yes, in thyroid you say I'll proceed with a quadruple assessment of this patient. I have already done the history and examination part. Now I'll do the remaining part of the quadruple assessment, which will include number 1, clinical part is done,
and the second is ultrasound of the neck and
ultrasound,
the thyroid,
then
neck. And third is FNAC,
histological proof, and a
thyroid.
thyroid profile study, which will be a screening for TSH. If the patient does not have any symptoms, if the patient has some symptoms of hyperthyroidism, you should go for full thyroid profile, T3, T4, TSH. Otherwise, this. Now you come to ultrasound. Actually, not about church.
Yes,
Please.
in ultrasound, what would you advise when you write down ultrasound? What would you advise on your on the patient's prescription?
Ultrasound.
Just ultrasound, huh? Any particular? I mean, there are different types of probes, isn't it? So you'll prefer doing an high frequency.
High risk.
Yeah, high frequency with you prefer to use high frequency transducers, isn't it, of the soft tissue of the neck? So what are the informations that you can get from an ultrasound of the neck in this?
And I think, as you asked, that what he should write, I think he should write ultrasound of the neck and USG guided FNAC from the
yes, what
because
together?
he
Any
not
suspicion?
you, and again you write FNA.
Write down,
When
yeah.
you write USG, you should write this whole statement: USG and USG guided FNA from the thyroid nodules. Okay. What do you find?
What are the informations that you can gather from an ultrasound?
You can pick out the nodules which are 2 to 3 mm in diameter, and it can pick out solid and cystic components.
Yes.
And USG guided FNAC.
Solid and cystic, or whether the nodule is cystic or solid. If it is cystic, whether it is simple cyst or it is a complex type of a cyst. Then
it can be used for USG guided FNA.
Before that, some more information I can get.
What are the other
FNA, there are some other things, so many things.
So many things.
Vascularity of the.
What are the sonological findings of a suspicious nodule as far as malignancy is concerned? What are the findings that will alert you that it may be harboring a malignancy?
Microcalcification, lobification, and taller than wider.
There are five suspicious features of malignancy, on the basis of which you will classify this as thyroids 4, ABC, and thyroids 5. So what are the 5 things? Number 1 is, you said, microcalcification. Then microlobulation. Yes.
Then taller than wide.
Taller than wider. What else?
In taller than wider, you better say that in one section, which transverse sections, transverse views. Okay, it will be taller than wider. Next,
stiffness, solid nodule. Stiffness, if we possibly assess by elastography. Okay, so these are the 5 features. These are the 5 features that take into consideration to classify this into T4, A, B, C, and T5.
Okay.
And then you
can.
Hello.
And we can find vascularity of the gland, and it can be used for USG, can be used for follow-up, and it can
before follow-up. At the moment, you have not mentioned about extrathyroidal extension. When you insert the gland, you can see the outline of the gland, and you see a smooth, clear outline, which is a capsule. You can demonstrate extracapsular extension of the tumor. This tumor can permeate along the interjugular vein lumen. That is one way of spread of the thyroid malignancy. So you can insert the interjugular vein and find out whether the vein contains only blood or there is tumor permeating the vein itself. And then you have lymph nodes. Top of that, before you go to follow up and other things, you are looking at a neck gland. What in ultrasound findings will say this is a metastatic gland? What are the ultrasound features of a metastatic gland?
So it's a shape.
First study size. Any lymph nodes in the neck more than 1 centimeter is significant node. Next, shape. Good.
From the kidney shape, oval shape to the spherical.
Yeah.
And second is the hilum.
Yeah.
And
what? Hilum what? Loss of?
Hilum.
Yeah.
Then
Center of the lymph node normally appears hypoechoic. Okay, because of the medulla. Now you have metastatic cells here. The central halo will be lost. Then junction of the lymph node with the normal tissue, there is a cleavage. You will find a peripheral halo in a normal node. In a metastatic node, this peripheral halo may be lost. And the outline of the node is smooth, a normal node. A malignant node may appear irregular outline, or there may be external extension. And you apply Doppler probe over this, you may have
increased
vascularity. So many things. These are all important. You should keep it. These are the things, if you can say straight away. In DNB exam, you see, now, if you have this OSCE type examination, there is a preset 3 points. So they earmark 3 points, 3 marks for this, and they mention 3 points to be mentioned. So you mention 3 points, you get full 3 marks. You mention 2, you get -1. So you have to be very specific. What are the things you are looking at?
And finally,
USG can guide your FNA. So what is thyroid system of reporting? Thyroid system of thyroid imaging reporting?
Yes, 1, 2, 3. One is normal thyroid.
Just give an outline, not going into details of everything.
One
it is expressed as T1 to T6.
One is first is normal thyroid gland.
Yeah.
Then benign, probably benign.
Yeah.
And then suspicion of malignancy, probably malignant, and biopsy proven malignant.
Yes, good. Now you have done FNA. Okay.
what would you write? Like FNAC from all nodules, or what are the nodules which will you target on FNAC?
Not on the necrotic nodules.
What is the term?
Internodules.
Suspicious nodules.
Suspicious.
The point is, you take the FNA from the suspicious nodules. Suspicious nodules, the nodule which is complex cyst, the nodule which is more vascular. Okay. The nodule which is more solid.
More solid, more dominant, like the other, I mean, much larger than the rest of the nodules.
So it is from multiple sides, but from the suspicious nodules.
Okay.
And how is the FNAC being reported as per?
Bethesda grading.
Okay. Okay. So you corroborate your clinical diagnosis. You say appearing a benign lesion. Okay. There is no suspicion of neoplasm. It's not a carcinoma. It's a benign looking colloid cells. Okay. How will you proceed?
I'll do other investigations for the management of treatment for the patient, like complete hemogram, along with that urea creatinine, sugar, everything. And I'd like to do a chest X-ray and X-ray, along with this X-ray neck of the patient, both AP and lateral. And I like to do an ENT examination, indirect laryngoscopy for the patient before proceeding for the surgery.
Would like to do a serum calcium also?
Why? Why serum calcium?
To rule out in post-operative.
Yeah, it is better to have a baseline calcium value, because patients who are already calcium deficient, they may develop very early hypocalcemic features. So it is wise to do a baseline calcium level in this patient. We are not suspecting hypocalcemia, but a baseline calcium is desirable, so that in the post we can think of whether the patient has got any evidence of hypocalcemia, and then these are the patients who develop hypocalcemia quite early.
And regarding why do you do an ENT examination, as you said, indirect laryngoscopy? Why?
For medico-legal purpose.
First is not medical legal. Medical is the next part. First is what?
Vocal cord palsy.
Yes. Some patients have asymptomatic vocal cord palsy.
Yes.
That is patient. Medical is the next part. That is different. But the first thing is, some patient may have asymptomatic vocal cord palsy.
And is there any role of what do you call it, radionuclide scan in the in multinodular goiter?
Yeah. Would you like to do a radionuclide scanning in this patient?
Need not be done. No.
Need not. Justify. Why? Because in our student days, anybody comes with thyroid swelling, it was a routine to write a radionuclide scanning. Now you are not doing. Why you are not doing? Why you not advise a radionuclide scanning in this patient? Then answer the reverse part. How a radionuclide scan helps in thyroid gland evaluation?
In this case, it does not say
Not
whether
this
it's
case.
nodule.
I mean, you're not answering this case. That's why I'm asking. How a radionuclide scan helps in evaluation of a thyroid.
It helps in the case of toxic adenoma and solitary thyroid swelling.
So if you number one, if you suspect it's a toxic multinodular goiter, we need to know which part of this goiter is hyperfunctioning area. Number one. If it is solitary nodule and patient is hyperfunctioning, we need to know which part of the gland is hyperfunctioning. The nodule is hyperfunctioning or the rest of the gland is hyperfunctioning. So that you can pick up by doing a radionuclide scanning. And the limitation of radionuclide scanning is it cannot pick up thyroid nodule which are less than 5 millimeter. It cannot pick up.
And it cannot say.
What is the status of doing a radionuclide scanning in management of thyroid disease now at the moment? What is the status?
It can be used.
One is you say toxic adenoma
and second
or toxic meningia, and second, third
for
is
follow-up of after thyroidectomy for cancer.
Yes.
For follow-up.
This is done as follow-up of patients who are undergoing treatment for thyroid cancer.
And ectopic thyroid.
Yes, ectopic thyroid tissue. Agreed.
And retrosternal prolongation, if you're suspecting that, that can also better delineate that, isn't it? Substernal, how far it has gone. Has it got some importance to know whether how far the retrosternal prolongation has taken place?
Or any, so we can do a CT chest.
Yeah, I mean, yeah, that is supplementary. Yeah, what is the importance of noting the, how far it has gone behind?
Whether it's operable from neck or it need a thoracotomy.
Yes, what are the indications radiologically which will suggest that the patient will require a medial sternotomy, not thoracotomy, sternotomy, for tackling the retrosternal prolongation? Hmm? There are certain indications, clear-cut indications. Like, for example, if the volume of the thyroid is more than 30% of the volume of the thoracic inlet, that can be assessed by CT scan, as you said. If it has gone up to the arch of aorta, if it has encroached, if it has gone to the posterior mediastinum, if it is engulfing the veins in the within the thorax, these are the indications where you should go for. You need to go for a median sternotomy. What radionuclide would you prefer for routine, for scanning only? What radionuclide? When it is indicated, of course.
We use technetium 99 or we can use iodine 112.
Why technetium 99 is preferable?
Because it's short. It takes shorter time to do that, and it can be.
Is it got a very short half-life also, isn't it? And you can pick up the picture within almost 20, 30 minutes of injecting the radionuclide, isn't it?
Yes.
Any other investigations? You mentioned about, CT MRI also you mentioned already. Yes, sir. Next.
So what's your plan? I've given a scenario that this patient has got clusters of colloid cells and suggesting a simple multinodular goiter. What's your plan for this patient?
I like to do a subtotal thyroidectomy for this patient.
Yes, subtle thyroidectomy. You said multinodular goiter involving the both lobes and isthmus.
Why not a total thyroidectomy?
Because more chance of injuring the recurrent laryngeal nerve and parathyroid gland during the surgery. So I like to do subtotal.
If the patient is in a good high volume center,
I think it is just the reverse. Rather, I would rather prefer a total thyroidectomy because if it involves, as you said, it involves both the lobes and isthmus, and there is a high risk of recurrence of this condition if you leave behind thyroid tissues. And if a patient requires a second loop surgery, that carries a far more higher risk of injuring the recurrent laryngeal nerve and the parathyroid. So, and as it is, patient is just only require some supplementation of thyroxine. That's all. So many people take thyroxine throughout their life. So what difference does it make? Isn't it?
can you tell the near total instead of total thyroidectomy? Near total, Dr. Horchak? Hey, can you tell near total thyroidectomy?
Yeah, he could say that near total, but
okay, because you see, with a patient having a multinodular goiter, most of the time these multinodular goiter people are having actual hypothyroidism. Once you do operation for this patient, you are leaving behind some tissue which are not normal because it's a diffuse involvement of the both lobes. So now one preferred treatment for these patients are total thyroidectomy, and provided that patient is being operated by an experienced surgeon in a good setup. Patient who is not experienced even subtotal thyroidectomy, he can land up with parathyroid being taken off, and land up with leg and line being injured even in the subtotal thyroidectomy.
exactly.
Okay. What are the different operations in thyroid gland? One is said is subtotal. What do you mean by subtotal thyroidectomy?
Removal of the both the lobes and the isthmus of the thyroid gland, except the over the recurrent. I mean,
You say subtotal thyroidectomy. What does it mean? The term was very valid, and this is a term which is applied in a particular situation. Subtotal thyroidectomy is one where you take the both lobes and isthmus out, leaving behind an amount of tissue which is equal to the normal functioning thyroid tissue on each side. And how do you assess that? This thyroid tissue should fill that tracheoesophageal groove on either side. You would fill that tracheoesophageal groove on either side. And if you go by grams of tissue, they said 4 grams on each side, or a thumb-sized tissue. So subtotal thyroidectomy patient may not require L-thyroxine supplement in the post-op period. That is one. Subtotal. What is near total? What is near total?
removing of both the lobes and isthmus of the thyroid gland, and except along the thyroid tissue along the tracheoesophageal.
No. It's a ream of thyroid tissue. In near total thyroidectomy, you remove the both isthmus, leaving behind a ream of thyroid tissue along the recurrent nerve, and there the patient will require. This is not a thyroid tissue enough to supply you the L-thyroxine. So this is a patient who will require L-thyroxine supplement. And total thyroidectomy is complete removal of this. What do you mean by lobectomy?
Removal of one lobe along with the isthmus.
Yes. Now hemi term is not used always. The lobectomy means one lobe and the isthmus, complete lobe and one part of the isthmus. What is Hartley downhill procedure? Hartley downhill.
One side subtotal is done, and the other side is we are leaving behind the thyroid tissue. I mean, along the.
No, it's not. Hartley downhill is one complete lobe, isthmus, and the other side you leave behind an amount of tissue which is normal. That is Hartley downhill. That means subtotal on the other side. The other side is not laid behind, the other side is removed. And there are some operations we call as isthmusectomy. Once you have a disease confined to the isthmus, having a nodule, you can do isthmusectomy, leaving behind both the normal lobes. And there is another operation known as isthmusotomy. Patient having anaplastic carcinoma, which is locally advanced, you cannot operate. Patient having distress, Sometimes this can be relieved by making an incision on the isthmus, known as isthmusotomy. So these are the different operations in thyroid gland.
Or reduced thyroiditis also.
Yeah.
But it compresses the thyroid. What complications can you expect following thyroidectomy?
It may be a hematoma, hemorrhage, and injury to the nerves, and parathyroid, injury to the parathyroid and also parathyroid deficiency.
You find a hematoma there, which is causing some amount of distress in the immediate post. Within few hours of surgery, what should be your approach to this patient?
In the ward, I open the sutures. And
Where?
The ward, in the neck.
Yeah. Then take the patient down to the OT and then try to secure any bleeding points. Okay. Next. Hypoparathyroidism, you said.
Yes.
So you should. It can be transient. It can be permanent, isn't it?
Yes.
So it may be either transient or it can be permanent.
Right.
Damage to?
Sir, I didn't get it.
Parathyroid injuries. Okay, now tell me, how can you prevent these parathyroid injuries from occurring peroperatively? What steps?
We can do localization of the parathyroid intraoperatively, and
Okay.
And inferior thyroid artery should be individual branches should be tight and securing the blood supply to the parathyroid. And we can do a system-based scan to localize it.
Yes, we can't do intraoperative scan.
Preoperative.
Even not. So the idea is, what we said is, individual branches of the inferior artery should be ligated on the surface of the gland, not away from it.
Capsular.
Yeah, on the capsule of the gland.
And in case you find that you detect that you have already damaged, what do you do? The parathyroid, then what should be done?
You see, all four has come out in the specimen. What you can do?
I can reimplant in the brachiored in the forearm.
Yeah.
I cut into small pieces and I'll put it.
Yes. Or in the sternocleidomastoid muscles.
Okay, Dr. Borcha, we can take some questions from the audience. Any question in the chat box, or they have any? Dr. Acharji, any comment?
The discussion has been quite comprehensive. The discussion has been quite comprehensive, so I don't really much to comment about that. I can, for the benefit of the students, can just give my way of approaching to thyroid tissue, swelling in the neck. If the students have in his mind that first I have to be sure that this is thyroid tissue, and once they are sure about thyroid tissue, they should think about the functional status, the compression of surrounding two tubes, two nerves, two vessels.
Yes.
If it is malignant or not, and if it is malignant, the staging. Then I think they can approach quite rationally and scientifically. That's all.
Yes, very right. Dr. Maiti.
One question. Yes, Professor Saha and Professor Borcha very excellently discussed the case, and the student has performed very nicely. One thing I like to mention, I have observed that in the presentation, he has mentioned during the examination, lyse method. Instead of writing the lyse method in your presentation, you say, because what is lyse method? If I ask the student, what is lyse method? Can you tell me what is lyse method?
What is lyse method?
The examiner I sit in front of the patient.
Okay, but you have examined the patient both sitting in front and also you have examined standing behind, because examination will be complete. If you examine the patient,
don't make a heading that you are doing only lyse method. You can do both.
Both. You should not write that. And instead of writing or telling that it passes, the swelling passes deep to the sternocleidomastoid, always use the term the swelling is deep to the sternomastoid. Not mention that it is passing deep to the sternomastoid. You mention it is deep to the sternomastoid. That is okay. Okay, otherwise it is very nicely done and all important points have been mentioned and discussed very elaborately and very nicely. Thank you.
Yeah, there is a question Dr. Bashak has asked, how to follow up. You see, we have discussed today the simple multinodular goiter. Details of this follow-up will be in the patient has got a malignancy in the thyroid gland. Even if the patient has undergone total thyroidectomy, these are the patient who should be kept on supplemental dose of L-thyroxine, and you follow this patient up with serial estimation of TSH, which should be kept to the normal range. But for malignancy, the follow-up is different. We'll discuss in the discussion of carcinoma thyroid in a subsequent discussion.
Professor Saha, probably I have missed whether he has mentioned the examination of the abdomen or not.
Yes. That comes with examination. I told him to give a brief outline about all the systems. His examination, his history and examination is very good. He has comprehensively covered everything. Thus, I suggested few points that he should be more methodical.
Now, may I ask the questions to the student? What is the importance of examining the abdomen in thyroid cases?
Why do you examine the abdomen? Why do you examine the abdomen?
Thyrotoxicosis, maybe a congestive cardiac failure, maybe present with abdominal distension.
No, remember that examination of the abdomen in thyroid cases is important in malignant cases. There may be metastasis in the liver, so liver may be enlarged, as well as in the autoimmune diseases. Not only the liver, but spleen may also be enlarged. Okay, in Hashimoto's disease, in the spleen also may be enlarged. So that thing should be remembered, that examination of the abdomen for malignancy and for splenomegaly in autoimmune diseases.
Always this tendency.
Another question, why is there a test for tracheal deviation? That is described, the trail sign. Once you have, sometimes it's a large goiter, it is difficult to make out the tracheal deviation. In that case, you will find the trachea is deviated, the other side, the sternomastoid become more prominent. So that is the indirect way of assessment. That has to be assessed ultimately by doing a cervical X-ray. Okay, yeah, if there is no other question, we'll say goodbye for today. We'll meet on Thursday, 8:30.
Thank you. Thank you very much.
Thank you. Thank you, Dr. Varchach. Very good discussion.
Thank you.